We are so sorry for the delay, but we are waiting for Dr. Narayan to connect. He's having some trouble with his audio, so please wait.
Today also is not coming.
Dr. Narayana?
Volume something.
Dr. Narayana? Are you able to hear the voice?
It's not mute also, it's unmute only.
Sir, can you hear us?
I'll try from my phone, huh?
You can ask him to connect phone. That will be easier, I think.
Yes, ma'am. We've asked him the same.
Do it from mobile only, Siddhu. Huh? Yeah. This is here. The judging criteria. So, yes. Here, mark it. Yes. Yeah. Then, just once. Next one, you click here. Huh? Yes. Just once. The headphone input. Done nothing of the host. Here. One minute, will do it. Because I'm not confident. No, I can hear you. Yeah.
Dr. Narayana?
Yeah, speaking. Yeah. Good afternoon, madam.
Can you hear us, sir?
Yeah, I can hear you.
Yes, sir. Can we start the session?
Yeah, you can start. You can start. Yeah.
Thank you, sir.
Thank you, madam.
Good afternoon, everyone. Welcome to the 32nd Annual Conference of Karnataka Association of Community Health, hosted by Ramaya Medical College. I'm Sharanya and this is Surabhi. We are from 7th MBBS students from Ramaya Medical College. Theme for this year is Redefining Public Health, COVID-19 and Beyond.
Yeah.
With this, shall we begin our session?
Yeah, you can begin. Yeah, start.
Can you quickly tell us the rules and regulations? What we say, it is 6 minutes plus 2 minutes and 10 slides. Anything else which you need to keep in mind?
Yes, ma'am. I'll tell it in 2 minutes. I'm glad to invite our esteemed judges. Dr. Narayana V. was the professor and head of department from Father Mulla Medical College, and Dr. Farah, associate professor from St. John's Medical College, Bangalore. We are really glad to have you here, ma'am and sir. We are very thankful for dedicating your precious time judging this event. Can I verify the participants? Dr. Steffi Francis, Dr. Saraswati V. Sajjan, Dr. Ravi Shankar Suryanarayana, Dr. Rachana A.R., and Dr. Ishfaq Nazir Bhatt.
Yes.
Yes. Regarding the rules and regulations, it is 6 plus 2 minutes, that is 6 minutes for the presentation and 2 minutes for the judges to ask the questions to the participants. We'll start our session. We'll begin with Dr. Steffi Francis. Dr. Steffi.
One question, will you be ringing a bell or something at the end of
Yes.
6 minutes? How will you indicate?
We'll be reminding you at 5 minutes, that is 1 minute before the end of the session. And then we'll
Okay.
stop the timer at 6 minutes, ma'am.
Okay.
Excuse me, I also have a question.
Yes, sir.
Yeah, my PPT, how do you, I need to upload the PPT?
Sir, you have to share the screen and not the presentation. You have to share the screen.
Share the
There's
screen.
an option for sharing the screen.
Sir,
Okay.
we will give you we will assign
Yeah.
the presence control to you, so you can share the screen after this.
When it's
Okay,
your
okay, all right,
you share
okay.
the content.
Got it, thank you.
Okay. I'm assigning Steffi, Dr. Steffi, to present.
You should be able to present now. I request everybody except the participant to mute so that there is no disturbances.
It is on. Dr. Steffi, are you able to share the screen?
Video is open, it is open. So,
Yes, ma'am. Dr. Steffi, we are able to see your screen. Can we start the timer? Dr. Steffi?
Dr. Steffi, we can see your presentation. Can you please unmute and start presenting? Dr. Steffi, we can't hear you. She's not unmuted. Dr. Steffi, can you please unmute yourself? Dr. Steffi, we are unable to hear you.
If you have a phone number, please call her up.
Okay, ma'am, we'll call her up. Can we move on to the next participant so that
Yeah.
the program
Good.
can run?
That will be nice. Yeah.
We have passed on control to Dr. Saraswati. She can start presenting now. Dr. Saraswati?
Yeah. Should I share my screen one?
Yes, ma'am. You should share your screen and not the PowerPoint presentation.
Sure. Just a second.
Yes, ma'am.
Is my
Ma'am, we
PPT
can,
visible?
yes, ma'am, we can see your screen. Can we start the timer and start the session?
Am I audible? Am I audible?
Yes, ma'am, you're audible. Can we start the timer?
Yeah.
Thank you.
Good afternoon, everyone. I'm Dr. Saraswati V. Sajjan, Assistant Professor, Department of Community Medicine from ESIC Medical College, Kalburgi. I'm presenting a study to estimate the prevalence of undernutrition among children in the age group of 1 to 5 years in urban Ballari. Children of today are the citizens of tomorrow. That is why it is very important to ensure adequate nutritional status for the children. The growth and development of the child is a strong reflection of country's growth and development. Being the most vulnerable segment of the society, the preschoolers are at greatest risk of malnutrition, since it is their growing period which demands excess consumption of proteins and calories. As you can see from the Karnataka State NFHS report, around 32.9% of the children in the age group of 1 to 5 years are underweight. And Ballari is one of the regions of Hyderabad, Karnataka, wherein there is minimal literature available about the magnitude of undernutrition problem in urban Ballari. Hence, an attempt is being made to study the same with an objective to estimate the prevalence of undernutrition among children in the age group of 1 to 5 years in urban Ballari. This is a cross-sectional study conducted for a period of 1 year in urban Ballari, and the sample size was calculated by taking the prevalence of underweight, which was 38 according to the Karnataka State NFHS report, and this sample size was worked out to be 700. Stratified random sampling technique was used, wherein there are 35 wards in Ballari city, and the list was obtained from the Municipal Health Commission. In each ward, the required number of study subjects was calculated by dividing the sample size by number of wards, which came out to be 20 children in each ward. So in every ward there were 3 to 4 areas. So one area among each ward was selected by lottery method, and in this selected area, house-to-house survey was conducted till a desirable sample of 20 children was obtained. Data was collected after taking informed consent from the parents or guardian, and by personal interview of the parents using semi-structured questionnaire. This was followed by anthropometric measurement of the child, and then the data was entered into the Excel sheet and analyzed. Descriptive statistics like percentages, mean, and standard deviations were used to describe the data. The socio-demographic profile of the study subjects showed that most of them, around 64.2% of the children were in the age group of 3 to 5 years. Boys and girls were equal in the study, and most of them, that is 71.6%, belonged to the Hindu religion, and 25% of the participants were Muslims, and 2.6% were Christians. Around 85.7% of the participants were having only one working parent, and around 46.4% of the children belonged to class 4 according to modified Kuspuswamy socioeconomic status classification. The nutritional status of the child based on weight for age according to WHO standards showed that 59.4% of the children were having normal weight for age, 22% were moderately underweight for age, and 18.6% were severely underweight for age. And this thing is depicted in the figure 1. The overall prevalence of underweight for age was 40.6% in the present study. The overall prevalence of stunting was 43.2%, and the overall prevalence of wasting was 23.9% in the present study. Here it clearly shows that in the present study, the prevalence of undernutrition was higher when compared to the state averages, and similar higher prevalence was also noted in other studies conducted by Tripathi MS et al. In 2006 in Udaipur, Rajasthan, and Meshram et al. In Surat, Gujarat in 2016. Whereas low prevalence of undernutrition when compared to the present study was seen in studies conducted in Belgaum, Karnataka in 2010 by Mattad V et al. And in West Bengal in 2008 by Baisai S et al. So this results clearly show that there is high prevalence of undernutrition among children in the age group of 1 to 5 years who are residing in the urban wards of Ballari city. Unlike in the rural areas, undernutrition is also prevalent in the urban areas. So I would like to recommend that since the parents are unaware about the nutritional status of their children,
Sorry to
arranging
disturb you, but 1 minute is left.
Yeah. So since the parents are unaware of the nutritional status of their children, arranging awareness programs at the schools or the Anganwadis for these parents, so as to make them aware regarding the nutritional status of their child is necessary. And direct intervention strategies with nutrient-dense food formulations, which are coupled with nutritional education, is the need of the hour. These are my references. Thank you.
Thank you, ma'am, for the presentation. Over to you, judges.
Dr. Saraswati, thank you. That was a nice presentation.
Yes, ma'am.
Can you tell us how did you standardize the equipment that you used to measure anthropometry, and what are the anthropometric measurements that you measured? Two questions. What all did you do, and how did you standardize the equipment?
Yes, ma'am, I have measured weight for age, and height, as well as mid upper arm circumference, ma'am.
Okay.
I have used for height, I have used the height measuring stand, and for weight, I have used the usual weighing machine. And before taking the weight, it was I saw that it was corrected to 0 for every side. And then for mid upper arm circumference, I used the measuring tape, ma'am.
Dr. Saraswati, weight is one very important indicator. What I wanted to know is what did you do to make sure that the weighing scale was working correctly? Some weighing scales show 1 kg more or 1 kg less, no? So what did you do to make sure that your instrument is working properly? Did you standardize it in some way?
Ma'am, I have checked there were 2 weighing machines, ma'am. I have before taking the weight of every child, I made sure that it comes to 0. So
you have not you used an analog scale or a digital scale?
It was digital, ma'am.
So you got the weight like 20.7, something like that?
No, 0. From 0 I started.
No, from 0 you started, but was it a dial scale or was it a digital scale? You got it for the first decimal place?
Yes, ma'am, yes.
Okay, so there are some methods of standardizing equipment. Have you used any of them? Because weighing scales, they can show mistake, no? Consistently, a weighing scale may show 2 kgs less. That will affect the prevalence of malnutrition in your study. So have you done anything?
No, ma'am.
Okay. Thank you, Dr. Saraswati.
Thank you, ma'am.
Narayan sir? Narayan, yeah.
Hello, am I audible?
Yes, sir. Yes, sir.
Hello?
Yes, sir. I'm audible, sir. Sir, you are audible to me, sir.
Yes. Yeah. Dr. Saraswati?
Yes, sir.
Your presentation was good.
Thank you, sir.
Now, what was the need for this study?
So when I had started this study, sir, this was done in the urban Ballari, sir. I searched for the literature. There were no studies available about the nutritional status in the urban Ballari. And this Hyderabad, Karnataka region, it is known for high prevalence of undernutrition in the children, sir, like the Raichur, Ballari, Gulbarga, and Yadgir district. So I just wanted to find out what was the prevalence in the urban Ballari, sir. Because it is always assumed that in rural areas the prevalence is usually high. But my study showed that the prevalence is high even in the urban areas also. That is what I wanted to see from this. Yes, sir.
Okay. So what was the prevalence? What was the prevalence?
Prevalence. Yes, sir. The prevalence of underweight for age was 40%, sir.
Okay.
40.6%, and the stunting was 43.2%, sir, and wasting was 23.9%, sir, in my study.
Yeah.
Dr. Saraswati, did you do the study during lockdown? When was data collection done?
2017 and 18, ma'am.
So, how did you? Most children would be in schools and Anganwadis. How did you ensure that you were able to get the children, your study population?
Ma'am, these are preschoolers, ma'am, 1 to 5 years, and nearby
they would be in Anganwadi. These
yes, ma'am,
children would be in
nearby.
Anganwadi.
Yes, ma'am. Nearby Anganwadis, since the Anganwadis were nearby their home, we visited the Anganwadis also, and then we asked in which home they stay, and then we inquired their parents.
But
about,
you said you went door to door, no? You went door to door,
door to door. If the child was in Anganwadi and it was nearby, then we went there, ma'am. Yeah.
Okay. What about children in private schools?
Private schools.
Preschools.
Usually.
Montessori's, preschools, English medium schools. Nobody was there?
Ma'am, I didn't find any such children, ma'am, during when I was doing this.
Okay.
Usually they were going to Anganwadi or they were at home.
Okay.
Yes.
Hello?
Yes, sir.
Yes.
Dr. Saraswati?
Yes, sir.
What were the limitations in your study?
Sir, I didn't hear it.
What were the limitations in your study?
Limitations, sir, since this study was, it was a quantitative study, I could not assess their exact nutritional needs, sir. And so because of that, qualitative study is necessary. And since I have done this in the urban area, sir, I cannot generalize it to the rural population, sir. I can only generalize it to the urban children staying in the urban areas with similar settings, sir. That was my limitation.
Okay. Then okay.
Kelly, sir.
Okay, Dr. Saraswati.
Yes, sir.
Did you take the ethical clearance? Institutional ethical clearance has been taken. Where is it? Show it.
So I have taken, sir. After that only I have started the study, sir.
You are not mentioned in the study.
Yeah, there was limitation of slides, so I couldn't incorporate everything, sir. I have taken this ethical clearance certificate.
Okay. Thank you.
Dr. Saraswati, last question.
Yes.
How does your data compare with data from Anganwadis? Most of the children you said were from Anganwadi. So have you compared your undernutrition prevalence from the data available in Anganwadis? Number one. Second question is, yeah, tell me. Go ahead. Tell.
We asked the CDP. We asked the CDPO, ma'am. But there was no, up-to-date data available regarding their nutritional status, ma'am. So we have, I didn't inquire about that, ma'am.
Okay. Did you find a difference between children going to Anganwadi and not going to Anganwadi?
Yes, ma'am. There was, I didn't compare exactly, ma'am, but yes, there was difference because they were issuing nutritional supplements like grains and all in the Anganwadis, ma'am. But I also encountered that few of the families were not enrolled in the Anganwadi. So that they were also complaining yes, they have difficulty in feeding their children in few areas, ma'am.
Okay, thank you, Dr. Saraswati.
Yes, ma'am. Yes, ma'am.
Let's move on to our next participant, Dr. Shankar.
Should I stop sharing?
Yes, stop. Yes, ma'am. Please stop sharing. I'll give the control to Dr. Ravi Shankar. Thank you so much, ma'am.
Yeah.
Dr. Ravi Shankar, I've given you the control. Could you please unmute and let me know if you're able to present?
Yeah, screen sharing is not unmuted. Still unable to share.
Yes, 1 minute, sir. Just a
Yeah.
sec. You should be able to present now, sir. So are you able to present? Yes, sir, we can see your screen, but we can't see your PPT yet.
Can you see?
No, sir, we can't see your PPT. You'll have to open the PPT. No, sir, PPT is not visible. Now it's visible.
Only.
It's visible now. It's visible. The presentation is visible now.
Visible now. So go ahead with the presentation.
Yes, sir. You can start. We'll start the timer now.
Good afternoon. My topic of the study will be exclusive breastfeeding practice and factors associated with its survival. That's what I had chosen. And exclusive means that the infant is only breastfed control, except for some. And worldwide are
Sir,
exclusively
I'm sorry to
breastfed.
interrupt you, but your voice is breaking, sir. So we are not able to hear you properly. I think it's a connection issue.
Only 35% of the breastfed in the first 4 months, and the exclusive breastfeeding practice in developing percent. Breastfeeding reduces morbidity, mortality. You know, health and care. It lays a platform for healthy, strong younger population. And also, hence, the study was planned to conduct on exclusive breastfeeding. The main objective is to determine the
Slides are
survival
not changing, Dr.
exclusive
Ravishankar.
breastfeeding.
Your slides are not changing. We are still in slide number 2. We can see slide number 2. Author slide. After that, we have not been able to see.
See this slide. I'm changing. I think there is some problem. Third slide.
Sir, you'll have to share your screen, not the presentation, the screen or whole screen. Then we'll be able to see when you switch the slides. No, sir, we can't see the next slide yet. I think, sir, you can start presenting again. I think it might work. No, sir, still on the author slide. So it's not changing.
Okay.
No, sir, just stop presenting and then start presenting again. Sir, could you share your screen now? If there's a problem, then we'll continue with the other participants because we are running out of time.
Yeah, that's it. I'll join you later.
Okay, so we'll continue with our next participant, Dr. Rachna. Ma'am, I'll give you the control. You can share your screen.
Yes, ma'am. Yes. Which side visible, madam?
Not yet, just a second. Ma'am, I can't see your presentation. Uh, yes, ma'am, it's visible now. You can start your presentation.
Okay, thank you. Good afternoon, everybody. I'm going to present a study on contact screening and isoniazid prophylactic treatment among the contacts of positive pulmonary tuberculosis patients in the coastal district of Karnataka. Show, or is it okay?
Yes, ma'am. Yes. If you can
Yes.
put it in a slideshow, it'll be better, I think.
Is it okay?
Can't see it, ma'am. It's okay, ma'am. Yes, ma'am. You continue. It's okay, ma'am.
Introduction. The close contact with a case of smear positive TB are at the higher risk of Mycobacterium tuberculosis infection and the TB disease. Hence, the WHO recommends screening of household contacts. And the active case finding strategy to increase the detection of TB is the key component of TB control program. Contact screening and as well as the isoniazid prophylactic treatment among the children is effectively reduces the risk of TB by 59%. It is proven by a meta-analysis, but its implementation at household level is less assessed. Hence, the field-based study was conducted with the following objectives. First, to assess the proportion of the contacts of positive pulmonary tuberculosis patients who have undergone contact screening in the coastal district of Karnataka, and to assess the proportion of children on isoniazid prophylactic treatment among the positive pulmonary tuberculosis contact in the coastal district of Karnataka. Coming to a study design, this study is undertaken after getting a approval from the institutional ethical committee. It is a cross-sectional study done at a one tuberculosis unit. It is attached to a government medical college. The study subject is that the sputum positive pulmonary tuberculosis patients and their contacts who are registered and treated under the dots in the study setting during the study period. The study period, it was done between the 1st July to 31st December 2019. Number of sample size is 104 contacts and 38 sputum positive patients. Coming to sampling technique, we did a clip enumeration. Study tool was a retested semi-structured questionnaire, which is administered by interview technique. Inclusion criteria was all sputum positive, all new and retreated smear positive pulmonary tuberculosis patients and their contacts. Exclusion criteria, the sputum positive TB patients and their contacts were not available for interview even after 2 visits of their home visits. Coming to the results, coming to the distribution of subject according to socio-demographic profile, majority of the were in the age group of 18 to 60 years. Majority were male. Coming to education status, they were studied, 22% were studied up to high school, followed by primary school. Majority of them were belong to a nuclear family, followed by joint and third generation family. Coming to socio-economic status, according to modified BG Prasad classification, 28% belongs to middle economic status, followed by upper middle and upper lower classification. Place of residence, majority belongs to urban area, followed by urban slum and then the rural area. Very important point to note here, the source of infection to the patients. 21% of the individuals that they got an infection by their household contacts, and another 79% from the outside. Coming to compliance with the treatment, almost majority of the 87% compliant to treatment in the schools and 13% were non-compliant to treatment. Into a contact screening and initiation of IPT, almost 97% of the individuals of contact of pulmonary tuberculosis patients were screened, and 5 of them were diagnosed with TB also, and they were on dots again. And 20 of the individuals had a contact, child contact, and those 20 were screened for symptoms of TB, and they were initiated with isoniazid prophylactic treatment. Coming to compliance, only 60% showed the compliance to IPT, and all 20 of the child contacts were immunized with the BCG injection. Coming to distribution of subject based on reason for non-compliance, 50% of them did not have adequate knowledge. That was the main reason, followed by 25% were scared of the adverse reaction. 12% of the individual disbelieved in IPT, and one of the individual also told that there was an irregular supply and follow-up by the healthcare worker. Coming to a conclusion, majority of the contacts were screened for symptoms of TB, and all the child contacts were initiated with IPT, but the compliance was not satisfactory. Recommendation we recommend with this study, fear of complication and poor knowledge about the effectiveness of IPT should be tackled with effective counseling. Healthcare worker education and securing stable medication supply and effective delivery of IPT are crucial for completion of IPT and reduction of TB risk. Thank you.
Thank you so much, ma'am. Ma'am, you can start asking questions now.
Thank you, Dr. Rachna. I have one clarification before I ask my question. This 104 was the number of TB patients or the number of contacts?
No, ma'am. These are the 38 were the TB patients and 104 were the contacts, ma'am.
So can you go back to that slide where you spoke about source of infection and compliance?
Yes, ma'am.
Yeah. Over here, what is your N?
Again, here is, sorry, in the upper two rows, it is 104, ma'am, and the lower two, it is supposed to be 38. There is a problem.
Lower two also don't add up to 38. Its first 3 are 104, and only the last one is 38.
Yes, ma'am. There is a confusion, ma'am. Actually,
I totally got confused because of this slide.
Yes,
Okay.
yes, ma'am. There was sorry. The 20% had given this thing. While calculating, it has changed it. It is 38, ma'am.
Okay, Rachna.
Yeah,
Thank
I
you.
have the yes, ma'am. Yes, ma'am.
Now you had two objectives. One, you wanted to find out the proportion of contacts who were screened, and among those who were found to be positive, how many are have been put on INS prophylaxis therapy? Correct? And
no, those who are positive for tuberculosis, they were put on dots.
Okay, correct.
That is, and then the child contacts who are negative for the TB were put on IPT.
Okay, correct. And you found that the proportion over here is very high. 95% of the contacts were screened.
Yes, ma'am. The 97%. Yes, ma'am.
And all patients were put on dots who turned positive, and all children were put on.
Yes, ma'am.
So, isn't this the objective of the program? What is the justification of the need for the study over here? That's a part of the program, and program is supposed to do it, isn't it? Isn't this a part of the
prophylactic therapy? How it is going on in the field? There is no there are no data available, ma'am.
with this the intention we started with this study. This was one of the intention of the study, ma'am. We have one more objective, but because of the time constraint and limitation, I could present only the one objective here, ma'am.
Okay. One more question, Dr. Rachna. You said your
Yes,
exclusion
ma'am.
criteria where you did not include people whom you could not meet after 2 visits.
Yes,
Isn't
yes,
it?
ma'am. Yes.
How many of those were there? How many such
Ma'am,
people did you have to exclude? I'm
ma'am, it was
asking
around.
because
Yes,
could
yes.
it be possible that people whom you excluded because you could not meet were the ones who were not on prophylaxis,
Maybe
or
on
whether
IPT.
the people who were not?
Yes, ma'am. Yes,
Which
ma'am.
is why
We
I
have
wanted to
collected.
know the
Yes,
non-responders
ma'am.
percentage
Ma'am,
or number.
around 8%, ma'am. And we have inquired
8%.
with the TU. Now they told that they no one had a child contact and they were not put on IPT.
Okay, right. Thank you.
Because
These are
these,
included in your 104?
so
No.
that was
Okay.
excluded. That was excluded.
Okay. Okay. Thank you very much, Dr. Rachna.
Yes.
Dr. Narayan, you can ask
Yeah,
questions.
yeah. Dr. Rajana,
Yes, sir. Thank you, sir.
it was a wonderful presentation.
Thank
Now I want to know how many slides totally you have used.
Sir, 10.
10. Okay, okay.
10.
Now
Yes.
in your study,
Yes, sir.
the contact screening was done, no?
Sir, tax screening was done, sir. 97%
So
of the individuals. Yes, sir.
what test did you do for screening of the contacts?
They had asked for a signs and symptoms, sir. Those who had a
Okay.
signs, if they had a symptom like cough with sputum, they were asked for microscopic examination. If the
Okay.
child contacts are the any other individual who are not producing sputum, they were asked for a X-ray, sir.
Okay. Did you do the Monto test?
Yes, sir. Child contacts they had done, but none of the children had a symptom, sir.
So how did you come to know that the children were having TB?
Sir, having the TB, sir, they were just the contacts of TB.
So they are not having TB. So on Monto test, what was the result?
Sir,
Hello?
sir, Monto was not done because they were not symptomatic, sir.
Okay. Only sputum examination was done.
Yes, sir. But if they had a symptom, then they were screened, sir. First, they used to screen for the symptoms of TB, like any of
Okay.
failure to gain weight or any symptoms, cough, sputum, or fever, intermittent fever. These are the things which were
Okay.
asked, sir. If they didn't had any symptoms, they were given with the IPT, sir.
Okay. So what was the sample size?
Sir, it was a complete enumeration. In the last 6 months, there were 38 patients enrolled in this TU, and their contacts
Okay.
were 104. So, actually, 124. We could not meet 20, around around 8%. We could not meet them, sir. So around 18
Okay.
to 20, we could not meet them. So, sorry, 8% of them were not available. So it was
Okay.
104.
It was a field-based study, no?
Yes, sir. It was a field-based study.
Okay, okay. So what is the prevalence of tuberculosis in your study?
Prevalence, sir?
Yeah.
Sir, prevalence of tuberculosis, it was not our objective of the study, sir. We could not do the prevalence. Only thing we did is like whether how many individuals were screened, proportion of individuals screened and put on IPT was our objective, sir. Sir, among
Okay,
screened
okay.
individuals, yes, sir. Among the screened individuals, if we can see, contact diagnosed with TB was 5, that is 4.8% of adults
Okay.
had TB, sir. Symptoms of TB and they were diagnosed with TB.
Okay, among the children?
Sir, the children, nobody had symptom and they were healthy.
Okay, okay. So what are the statistical methods you employed?
Sir, actually, descriptive statistics, the sample size was low, especially the IPT. Here you can see the sample size was low, so I could not apply
Okay.
any analytical statistical method here, sir.
Okay, you didn't use any statistical methods.
Sir, because the sample size was low, sir. I just had 8 of the individuals who were non-compliant among the 20.
Okay.
So I could not apply any of the statistical tests.
Oh, okay. Okay, thank you.
Thank you, sir.
Thank you so much, ma'am. Thank you, judges. Since we are running out of time, I would like the judges to limit the question answer session to 2 minutes.
Okay.
Thank you. Now we'll continue with the next participant. Our next participant. Yes, ma'am. Yes, ma'am. Our next participant is Dr. Ishfaq. Dr. Ishfaq, I will be giving you the control.
Thank you very much. So I'll share.
Yes, sir. You should be able to share now.
Share content.
Share the screen, sir. So that.
Okay.
Your slides are visible, sir. I'll be starting. Shall I start your timer?
Yeah. Okay. Thank you very much. Good afternoon, one and all. I'll be presenting my study on association between heavy school bags and musculoskeletal discomfort among students 11 to 13 years in rural Bangalore. As you know, musculoskeletal discomfort is a discomfort that affects the muscles, ligaments, tendons, and bones. Children carrying heavy school backpacks for school are at a higher risk of short-term and possibly long-term health issues. Recently, it's well noticed that a large number of children who visit hospitals are treated for their musculoskeletal problems. And our study mainly aims at throwing light on this problem the students face. Coming to the objectives, my objectives were to estimate the prevalence of musculoskeletal discomfort among students aged between 11 and 13 years in rural Bangalore, and to determine the association of school bag weight with musculoskeletal discomfort. Coming to the methodology, it was a school-based cross-section study done for a duration of 2 weeks. Sample size was calculated using the formula and taking prevalence of musculoskeletal problems among school-going children from the previous studies to be 60%. The sample size was calculated to be 104. Collected data was entered in Microsoft Excel sheet and analyzed using SPSS, trial version 20, and categorical data were presented using frequency and percentages in association between variables was done using chi-square test. Statistical significance was set at p less than 0.05. It was a multi-stage sampling done, and students in the age group of 11 to 13 years of rural Mangaluru were taken. In the inclusion criteria were students aged between 11 to 13 years who were medically fit and using backpacks. And exclusion criteria were those students with medical condition that could interfere with the study objectives and who had met with an accident or had surgery in the last 2 months. A pre-designed pre-tested questionnaire was used, which consists of 3 parts, part A, B, and C. A comprised of socio-demographic profile, part B had quantitative measures like height, weight, and body mass index, and part C was a pre-tested and pre-designed Cornell University questionnaire. Consists of asking the students 3 sets of questions and enlisting their response for each of the questions by showing the approximate position of the body parts referred for discomfort. A calibrated weighing machine and non-stretchable measuring tape was used, and students were from the 2 schools aged between 11 to 13 years were included. Prior informed consent was taken from the head of the institution as well as parents and guardians of the students, and were briefed about the questionnaire. Every student questionnaire was filled by asking questions and also noting down the relevant measurements. Ethical clearance was obtained from the Institute Ethical Committee. Coming to the results, table 1 shows the study parts in particulars. There were equal number of male and female and predominantly private school-going students. Table 2 shows the prevalence of musculoskeletal discomfort in the various anatomical body parts. Most of the school students had and never complained of any musculoskeletal discomfort. And table 3 shows the level of musculoskeletal discomfort in the various anatomical body parts. Herein also, the majority of the students had slight discomfort. Table 4 shows the degree of interference in the daily activities due to musculoskeletal discomfort. Herein also, a very minimal percentage of students had substantial interference with the daily activity. Table 5 shows the association of socio-demographic variables of the various study participants with musculoskeletal discomfort. Here, it was observed that 50% of the female students had musculoskeletal discomfort as compared to 28.9% of the male students, which was found to be statistically significant. Table 6 shows the association of musculoskeletal discomfort in relation to the body weight. Here, it was not observed to be statistically significant. Coming to the discussion, Table 7 shows a comparison of socio-demographic parameters in relation to the other studies. Here we had equal proportion of male and female students, which was also similar to the study done by Shamsuddin A. Whereas the study done by Pravaskar had predominantly private school students. Table 8 shows a comparison of the musculoskeletal discomfort and the anatomical body parts among different studies. Herein, our study observed that predominantly neck and shoulder had a discomfort, which was similar to the study done by Deepthi, done in Udupi. So these are twin districts, which may explain as similar in incidence of musculoskeletal discomfort in neck and shoulder. Table 9 shows the association of socio-demographic variables and other particulars musculoskeletal discomfort. Herein, only with regards to the gender, with female being more particularly vulnerable to musculoskeletal discomfort, and we found to be statistically significant, whereas other studies done by Whitfield had similar results. The study done by DPG had association with regards to school and mode of reaching school as well. To conclude, it was observed that 26% of the students in our study had musculoskeletal discomfort in the neck, while 35% had it in the shoulder region, which ranged from 1 to 2 times a week to several times a day. Less than 2% were seen to have discomfort in the upper arm. Among those students who felt musculoskeletal discomfort, it was observed that the discomfort ranged from only mild to moderate discomfort in all anatomical body parts, and only about 3.7% of students had a severe discomfort in the neck and 2.7% in the shoulder region. It was observed that among those students who had musculoskeletal discomfort, there were only slight interference in their daily activities.
So, sorry to interrupt.
It was also seen that among the parameters observed, 50% of the female students had musculoskeletal discomfort compared to 28.9% of the male students, which was found to be statistically significant. So recommendations, since the duration of the study was short, further in-depth analytical studies may have to be required to ascertain an association between school bags and musculoskeletal discomfort, and there should be a sensitization of the school teachers and parents about the potential health hazards of the heavy school bags. And there's a need to establish a uniform policy in schools on limiting backpack weight. These are my references. Thank you.
Thank you, sir.
Thank you, Dr. Ishfaq.
Thank you, ma'am.
Your title and objective says that you're looking at musculoskeletal discomfort among students in the whole of Dakshina Karnataka district.
Yes,
so how many schools did you include in your study, and were they government schools or private schools?
Ma'am, there was one government and one private school only, and within this in the south part of the district.
So do you think your results are generalizable to the whole district?
No, madam. There needs to be further, include maybe a little more than the normal this number to ascertain to get the correct picture of the musculoskeletal discomfort.
In the school, how did you select the students?
Ma'am, among the in the schools, initially we thought about doing the complete enumeration, but what we did was we selected the students in between the 11 to 13 age group, 6th and 7th standard. We did not take up the students who were more than that, because they had their exams, and lower than that, we could not have got the correct picture from the students. And taking these, we took the 6th and 7th class students, and we did the.
So you went to 2 schools and you have done complete enumeration of all the 6th and 7th standard students in those 2 schools, right?
Yes, ma'am.
Okay. How did you take assent from the students?
Ma'am, consent was taken from the hospital, college authorities, as well as their parents, a written consent. But we took the assent from the students. In that, we explained the exact procedure that we are going to undertake, and explained to them that this is we'll have to have your height and weight measurements by verbally explaining all the procedure.
Okay. This Conwell's questionnaire, is it validated for use in India?
Madam, this is an open access questionnaire, and I have also asked permission also from the said doctor to take and he has given me the consent, but this has been used in a number of studies. Ma'am, I have seen Nordic questionnaire as well as this questionnaire being used. in a number of studies.
Do you have data on sensitivity and specificity of this questionnaire?
No, ma'am, I don't.
Okay. Okay. Thank you, Dr. Ishfaq.
You're welcome.
Hello.
Hello. Yes, sir.
Dr. Ishwar.
Yes, sir.
It is a good presentation. Your study was good.
Thank you very much, sir.
So, yeah. So now, why did you take up this study instead of any other studies? Why did you take up study on school children weighing backpacks?
Yes, sir. I wanted to know whether I used to see a lot of conflicting statements whether musculoskeletal discomfort is related to the backpacks alone, or there may be other issues involved. I think it was just my interest to take up this study. Wanted to ascertain what is the level of discomfort that the students are witnessing because of and these days also a lot of news is there, and strict yardsticks are probably going to be put in place in terms of the number of the weight of the backpack. And also in some of the schools, there is some policy also to leave the school bags within the school premises so that the students don't have to, there has been started a little bit of, in some of the schools it has started, but there should be a uniform policy overall to take care of this very important issue.
Okay, did you weigh the school bags?
Yes, ma'am. Yes, sir.
So what was the maximum? What was the maximum weight of the school bag?
There was a few outliers were there whose school bags were more than 15 kgs, 15% of the body weights. But a majority of the students, a few of them, not much, not many.
Okay, so among those children who had more than 15 kgs, discomfort was there? Musculoskeletal discomfort was seen?
Yeah, but it was, I've observed a quite paradoxical picture. The increased number of as you increase the bag weight, the musculoskeletal discomfort was slightly lower than those who are having a lesser, say for example, less than 10% of the body weight. This was.
So it was not significant. It was not significant.
It's not significant, yeah. Probably more studies need to be done, more schools need to be taken up to get a correct picture.
Okay, so what remedial measures can you suggest? One, you told that they can leave the books in the school itself and go. Are there any other remedial measures?
Ma'am, sir, what I would feel is that there should be a uniform policy in limiting the school bag weight to a certain minimum. 10% is the suggestion of I think which are reasonable grounds to take up.
Okay, so have you heard of no school bag day?
Yes, sir. Yes, sir. I do. In
what is that?
Sir, in schools, they have started an initiative that once every week the students should not be carrying any school bags.
Okay. Thank you.
Thank you very much, sir.
Thank you so much, sir. Let's move on to the next participant.
You're very welcome.
Dr. Ravi Shankar.
Yeah, I'm there.
I'll be giving you the control. Sir, I have given you the control. We are going to end this session soon. So for the judges and participants waiting for the next session, I'm so sorry for the delay. We'll be starting soon.
Is it not downloaded, sir?
Format change.
No, it's okay, sir.
Dr. Ravi Shankar, are you able to present?
Sure. Able to see the screen, madam?
Yes, we can't see your screen yet.
Is visible, madam, now?
Sir, it's not visible. Sir, shall I present your PPT? I think I have the PPT.
Sure. That's fine. Is visible now, madam? PPT is visible, ma'am.
No, sir, it's not visible. Sir, can I present your PPT from our system and you can tell me when to switch the slides?
I'll put in the desktop, wait, sir. If he's not downloaded it. No, wait, don't go back. Don't go back. Let's see.
Ravi Shankar, sir, can you give me the control to present your PPT? Because I think you have the control right now. Dr. Ravi Shankar, can you please unmute?
Okay.
Sir, sir, you have to give me the control to present the PPT. So you can go to the participants and under Hall D, you will see 3 dots. So you can press that and give me the control because then I'll be able to present your PPT. Uh, Dr. Ravi Shankar?
How to give control, madam? There are 3 dots.
1 second. Just share it now. Just share it.
This first one.
First one.
Can you see the slides, madam, now?
No, sir, slides are not visible. Dr. Farah, ma'am, we have given the control to you. Can you please give it back to us? Can you make us the presenter?
1 minute.
Yes, ma'am.
I'm just trying to figure out how to do it.
Ma'am, if you can see Hall D, so you can see 3 dots on top. So you can assign the control to us.
Not Madi, sir. Okay. Was presenting.
Okay. I can. Do I have to go to participants to do it?
Ma'am, you can do it on the main screen as well. You can go to
Okay,
participants.
3 dots.
Yes, ma'am.
Switch speaker, mic, create shortcut, find a device, share content. Settings, is it?
Okay, ma'am, I got it, I think. 1 second.
You got it?
Sign privileges. Yes, I got. Oh, ma'am, I'm not able to do it. Can you try again, ma'am?
No, I'm not the organ. No, how do I do it? You tell me what to do, I'll do it.
Ma'am, can you see the 3 dots?
Yes, I can see the 3 dots.
Are you
Now it
getting
says
the last option as make presenter or assign
no,
privilege?
no, I don't have that thing. I think only the hosts will have it.
Okay, ma'am. We're actually trying. Okay, okay, ma'am. We got it. We got it.
Got it? Yeah.
Yes. Share screen. Ma'am, is the screen visible?
Yes, it is.
Okay, Dr. Ravi Shankar, shall I start your timer? Dr. Ravi Shankar? Sir, Dr. Ravi Shankar?
Yeah,
Sir, I can't hear. Sir, can I start presenting?
sure.
Okay.
Please put it on full screen.
Yes, ma'am.
Yeah. Good afternoon. My topic of presentation will be exclusive breastfeeding practice and factors associated with its survival. Next slide. I'm the first author Ravi Shankar and the co-authors Prasanna Kamath, Dr. Sunil and Dr. Mahendra. Next slide. So exclusive breastfeeding means infant receives only breast milk in the first few months of birth, and apart from oral rehydration solution, other syrups or medicines will be given. Only 35% of the infants worldwide are exclusively breastfed in the first 4 months. Exclusive breastfeeding practice in developing countries usually varies from 10 to 77%. Exclusive breastfeeding is very important to reduce as it reduces morbidity and mortality among infants and promotes better health and creates strong younger population, and it reduces economic burden also. Next slide, please. The main objective of this study is to determine the survival and prevalence of exclusive breastfeeding practice among rural population in Kolar district, and also to study the associated factors of exclusive breastfeeding practice among rural population in Kolar district. Next slide. So this is a cross-sectional community-based observational study. A sample of 441 mothers estimated, sample size was estimated based on prevalence of exclusive breastfeeding practice in NFHF survey 3, and it was conducted in 2005-6 with 95% confidence and a non-compliance rate of 15%, and all mothers with less than 1 year were included from 3 PH areas with the help of ASHA workers. They will have the records. According to that, we able to select using simple random sampling technique. We selected around 441 mothers, and ethical clearance was obtained. A pre-tested questionnaire was used to collect the information on demographic and duration of exclusive breastfeeding and factors associated with exclusive breastfeeding practices. Next slide, please. The data, it was statistical methods used was for quantitative data presentation, we use mean and standard deviation. For categorical data by percentages, so to study the survival, we used Kaplan-Meier survival analysis, and chi-square test and binomial logistic regression was used for data analysis. It was done in SPSS version 22. Next slide. And this is the basic demographic features with exclusive breastfeeding practice, and majority of the and most of the exclusive breastfeeding practice was around 32% in age group 18 to 22 years mothers, and as far as education is concerned, compared to literates, that is primary, middle, and higher education mothers have better exclusive breastfeeding practice, and education of father also played an important role here, where educated middle school and higher educated father, in their families, we found that exclusive breastfeeding was better when compared to illiterates. As far as occupation is concerned, though the main occupation of the respondents' family was agriculture, still they were able, nearly 48.8% of the people were able to provide exclusive breastfeeding practice. And then religion also played an important role, because most of the families brothers we interviewed were belonged to a particular religion, and also finally we found that religion also playing an important role. As parity increased, exclusive breastfeeding also started decreasing. Age of the mother also an important factor, which is indicating exclusive breastfeeding practice. Nearly 32% of the mothers exclusively breastfed who were married between 16 to 20 years. And birth order, and then number of ANC visits, birth interval, though they play a role, but in this study it was not found to be statistically significant. Place of delivery also, those who are delivered in government hospitals, because of the counseling and other factors, the exclusive breastfeeding rate was little bit higher when compared to deliveries conducted in private and other hospitals. Next slide, please. Next slide, please.
1 second, sir, 1 second.
Exclusive breastfeeding decreased with increase in maternal age. That was one important observation made. Association was found to be statistically significant also. Mothers having agriculture, unskilled work, and service as their occupation have exclusively breastfed their babies better when compared to other occupation like housemaking. Religion also found to be significantly associated with exclusive breastfeeding. Nearly 30 to 34% of the mothers with parity 1 or 2 have better exclusively breastfed their babies compared to the other parity groups. Next slide, please. So this is the exclusive breastfeeding practice observed. 2 to 4 months, nearly 13.8% of the mothers were able to exclusive breastfeed for babies between 2.1 to 4 months. And nearly 16.8% of the mothers were able to provide exclusive breastfeeding for up to 6 months. And more than 6 months, almost 70% of the mothers were able to provide exclusive breastfeeding practice. Next slide, please. Next slide. So this Kepler-Meyer survival curve indicate that exclusive breastfeeding prevalence was better in the early stages till 2-3 months. Later on, exclusive breastfeeding rate has decreased. Probability of providing exclusive breast milk was decreased, and after 6 months, exclusive breastfeeding was around 60-65%. That's what we see. The median survival of exclusive breastfeeding varied between 5 to 6.02, and median exclusive feeding was around 6 months. Next slide.
Sir, you have 1 minute left.
Logistic regression used to assess the risk factors or the factors associated with exclusive breastfeeding indicate that the factors like birth weight, birth order, and maternal age, factors like birth weight and birth interval had a negative association with the exclusive breastfeeding practice, whereas maternal age and birth order show a significant positive association with the exclusive breastfeeding practice. And even education of father, better educated parents or the father in the family, we expected that exclusive breastfeeding will be better, but it is going other way around. So, and other factors like mother's occupation, father occupation doesn't have any statistical significant association with exclusive breastfeeding practice. Next slide, please. Next. In conclusion, healthcare providers in the community should also be considering these cultural factors, because religion was found to be significant. So probably cultural factors are playing a role in low percentage of exclusive breastfeeding among mothers, and educate mothers for practice of exclusive breastfeeding and its advantages. Governmental programs to promote and support EBF should concentrate on better training for healthcare professionals. Mothers who work outside home are less likely to practice exclusive breastfeeding practice for 6 months. So there is a need to promote the workplace breastfeeding practice and creating an enabling environment for exclusive breastfeeding. Prenatal maternal
Your
knowledge
time.
and awareness may promote
Sir,
adherence to WHO
conclude that your
breastfeeding
time is
practice.
up.
Thank you. These are my
Thank you.
references.
Okay. Thank you, Dr. Ravi Shankar. I have a question regarding your outcome variable. Your outcome variable in your study is exclusive breastfeeding, correct? And exclusive breastfeeding by definition is up to the
6
age of
months.
six
6 months.
completed months,
Yeah.
correct? Okay, so two questions related to this. The first one is, you've taken children under the age of 1 year. So suppose suppose a child is 2 months or 3 months, how will you decide whether the child is exclusively breastfed or not? Because for exclusive breastfeeding,
we had a contact of ASHA workers and also the contact numbers of the mothers who are just delivered or the baby was 2 to 3 months, and we were able to follow them for this information when actually they started weaning, when actually exclusive breastfeeding was stopped. That information we
so
were able
at
to.
6 months, do you have information for all the children?
Yes, madam.
Because there was one slide where you put more than 6 months also. So some children were exclusively breastfed for more than 6 months, less than 6 months.
More than 6 months in the sense, those who have completed 6 months, they were considered as less than 6 months was considered as the survival. The event happened that period of time, and then equal to or more than 6 months, we consider them as completed the exclusive breastfeeding.
Okay. Uh, Thank you, Dr. Ravi Shankar. Why have you used NFHS 3 data for your sample size calculation?
No, actually, we started collecting this data in 2017. So in that, the latest information, that is the most documented information, was NFHS surveys. So that's why we consider that information.
Okay, because now we have NFHS 4 definitely, and
Yeah.
NFHS 5 data is also available.
Yeah.
And one of your introduction slides talks about 4 months of exclusive breastfeeding.
Yeah, that's most of the prevalence. What they observed is up to 4 months. Most of the information available, the exclusive breastfeed, up to 4 months was around high, but later on the exclusive breastfeeding from 4 to 6 months it has come down
Okay, thank
more.
you, Dr. Ravi Shankar.
Hello, Dr. Ravi Shankar.
Good
Hello.
afternoon, sir. Good afternoon, sir.
Hello. Yeah, your presentation was very nice.
Thank you, sir.
Congratulations.
Thank you very much.
Sir, this is a field-based study, no?
Yes, field-based study.
You did the study in in the community.
Community, considering ASHA workers who are working in the primary health centers, because they are the first-hand informers for us. So we were able to get the list of all the mothers who just delivered and having children less than 1 year of age. So we had a sample frame for that. From that, we were able to select 441 mothers.
Oh,
Child less than 1 year.
okay. So, dear doctor, what do you know about the baby-friendly hospital initiative? What do you know about it?
Baby friendly hospital is where the counseling happens for these kind of information, providing exclusive breastfeeding, nutrition for babies. It happens at the primary health center level. When we did that, it was there in the program, but actually the field level it was not happening. That's why we were interested in taking up the study. And in spite of, in addition to doing this, we were able to provide counseling and weekly clinics for those mothers to provide education
Okay.
for them.
So now, do you think that this BFHI program is implemented only in the government hospitals and the private hospitals are negligent about it?
Also, we should be the major stakeholders, sir, as far as private setup is concerned. So, government should try to involve especially departments like community medicine, pediatric, into this program, so that they can make this program successful. They can take it further.
Oh, okay. So one last question, sir. When is the World Breastfeeding Week observed?
Oh, no, sir, I don't remember, sir.
You don't remember? Okay, sir.
Thank you, sir.
Thank you.
Thank you.
Sir, thank you, judges. Now we have our last participant, Dr. Steffi. Are you here?
Am I audible?
Yes, ma'am, you're audible. Shall I give you the control? Yes. Uh, you should be able to present now, ma'am. Yes, ma'am, you have to enlarge it. Yes, ma'am, we're able to see your presentation. We'll be starting your timer now, ma'am. Ma'am, you can start presenting.
This is everyone. I will be presenting a study on constraints and barriers to cases of PMSMA receiving obstetric care in rural and urban setup in Nasik. Government of India launched PMSMA in the year 2016 to provide extra quality antenatal care, and it is conducted on 9th of every month. It focuses on the high-risk pregnancies, the missed out, dropped out cases, and also encourages public-private partnership. The objectives of the study were to identify barriers and difficulties PMSMA. And second one, to describe constraints involved in referral and follow-up of identified high-risk pregnancies to higher center. Methodology study design used was prospective cohort study, and it was done in two centers of Hassan district with the highest number of beneficiaries, one in the rural and another urban center. There were 16 PHCs included giving NSLA services. Of that, the highest number of beneficiaries were one in rural, it was in Saltana PHC, and urban it was Krishna Hospital. It was done from Jan 2018 to June 2019. Method of study collection was all pregnant women attending the PMSA clinics in the second and third trimester in the study area were interviewed, and the centers were visited alternatively every alternate month as the program is conducted simultaneously on 9th of every month. The details were collected, and all pregnant women were interviewed at least twice, once in second trimester and the second and the third trimester near their delivery. The results and socio-demographic characteristics noted were the age group wise, the beneficiaries majority belong to the 22 to 25 years age group, and it was noted in urban there were more of younger beneficiaries from 18 to 21 years age group. Again, region-wise, the rural center had predominantly Hindu beneficiaries, whereas in the urban it was more of Muslim population. 98 majority of them were homemakers, and education-wise, they were not very well educated, as only 15% were graduates and above. Compared to rural and urban, the urban population were were poor in education. Uh, in general, the rural beneficiaries were more from an agricultural background, and the urban population comprised mostly of urban slums population. Now moving to the constraints or barriers faced within PMSME clinics, the main barrier was lack of awareness, slaving 33.3% of the total beneficiaries interviewed. Out of the total pregnant women in both the centers, 62.5 beneficiaries, percent beneficiaries were identified who could not attend the appropriate number of ANC visits, and of which 20.6 were from the rural center and 12% from the urban center.
Hello?
And
Hello?
Hello? At the beginning of the study,
Hello?
we had anticipated,
Hello?
however,
Yes,
it was less
ma'am,
than
just a
expected.
second.
Hello?
My audible.
Hello?
Yes, sir, you're audible, sir.
Hello, it is audio is not correct.
Were overcrowded.
Audio is not clear.
Dr. Steffi, sir cannot hear your audio well. None of us can. It's kind of muffled. So, is there an alternative way you can speak in
Am
without
I
the
clear now?
maybe? What, ma'am?
Please use earphones, Steffi.
Am I clear now?
Ma'am, your voice is a bit unclear. It's a little muffled. Sir, Steffi ma'am is having some network issues, so I
Hello,
think
am
this
I
is the
audible
best
now, sir?
she can present.
Oh, okay, okay.
Sir, am I audible now?
Yes, ma'am, you can continue, ma'am.
Am I audible?
Yes, ma'am, you're audible. You can continue.
Can I hear? Can you hear me now, sir?
Yes, ma'am. Yes, ma'am, we can hear you, ma'am. You can continue.
Can I proceed? Sir, can I? Okay, so I'll continue. I hope I'm audible. Okay, thank you. Uh, okay, thank you. So one major constraint reported was lack of awareness. The next being lack of feasibility. Some others reported that the clinic was crowded. It takes a lot of time. There was lack of adequate facilities for management of high risk and precious pregnancy. Also, there was
Also, there was prejudice that the services were of poorer quality, and some mentioned that the ANMs come to give IFA tablets, and therefore it was not needed to visit the PMSLA center. That is, their full needs were already addressed. That's why they did not take the recommended visits. The total 10% did not of who were had high risk pregnancies. 10% did not comply with the referral advice. It was much less than expected. However, it is not insignificant. That is the main complaint from the rural center was distinct from the referral center. It was also told by some that was inconvenient, mainly due to certain family engagements or prior commitments. In two, they also reported lack of family support and accompanying person. So only 8 of the entire 81 who were advised referral did complain of any constraint. To conclude, the program has done tremendously, definitely has done well in improving the antenatal quality. However, the services quality has to be improved for improving the function of the program and to fulfill its objectives. Recommendations is as lack of awareness was reported, there is need for better education, communication, and social mobilization. Training of ANMs or MLHPs for identification of prompt referral of high-risk cases may, at the subcenter level itself, may reduce some constraints in referral. Modifications in timings will also be helpful for those employed and even for homemakers. Strength beneficiaries for personal interview to assess the constraints and barriers. And the limitations of the study was done in only selected 2 centers, hence you cannot generalize the finding to the entire district. Also, we had interviewed only beneficiaries who were attending the PMSL clinic. These are my references. Thank you.
Thank you, ma'am. Judges, over to you.
Thank you, Dr. Steffi. You wanted to find out the constraints. So what I want to know is how did you identify and where did you interview the ladies who were not availing services? Because obviously because of some constraint or barrier, they were finding it difficult to come to the center. So how did you, where did you interview them and how did you interview them?
Actually, that is one limitation of the study. At the beginning of the study, I had not. I had the plan was only to interview the PMSME clinics due to logistic feasibility issues. I could not also get the constraints of beneficiaries who are not availing the services.
Okay, so that would be a limitation. Second question is,
Yes.
your study shows that the women from urban areas were younger and they were less educated compared to women from rural areas. Any explanation for this? This is contrary to what we usually expect. Steffi, can you hear me?
Yes, the women from urban area were mostly of urban slums. They belong to the slum area, whereas in the rural area, they were more of. Am I audible?
Yes, Steffi, go ahead.
Hello, ma'am.
I can hear you, Steffi. Go ahead.
Yeah, so the women in urban area, they were actually of poorer background. They were those residing in the urban slums.
Okay.
Where,
Right.
yes, ma'am,
Thank you. How did you do the sample size calculation for your study?
am I audible now?
Yes, you're audible. How did you do the sample size calculation for your study?
Yeah, so the women in the rural area were those of agricultural background, but they were better educated and they had better
Okay,
socioeconomic status.
thank you, Steffi.
Which
I
I
got
couldn't
that.
display due to the limitation of the slide.
Okay, but have you done a sample size estimation? Steffi, can you hear me? Have you calculated the sample size for your study?
Sorry, ma'am.
Sample size calculation.
Hello, ma'am. The question was not audible.
Okay.
Question was not audible.
Have you done sample size estimation for your study?
Yes, sample size estimated was 250, which was divided into urban, 125 urban and 125 rural. It was based on the NFHS data.
Okay, thank you.
Thank you.
Hello? Hello?
Hello, sir. Hello, sir. I
Hello?
can hear you, sir.
You can hear me, Dr. Steffi? Hello?
Yes, sir. I can hear you.
Yeah, it was a good
Yes, sir. I
presentation.
can hear you, sir.
Okay, okay.
Thank
Now
you,
you
sir.
told that distance was a constraint for the program, national program. So have you recorded the distance which was the distance from the beneficiaries, how much distant they were from the rural health training centers and the urban health training centers? So those who did not receive the benefits, how much distant they were from the centers? Hello?
The urban centers, they were. Hello, am I audible, sir?
Yeah.
From the urban center, it is a densely populated area, and they were quite near the center. They were residing in
Okay.
slums around the PHC. As in rural area, it is a lesser denser area, and traveling
So majority of them
average
had.
rural area.
Hello? Yeah.
Yes, sir. I can hear you, sir.
So in the rural areas,
The
they were very far from.
distance,
They are very far from the
very
centers.
less than.
Hello?
Sorry, sir. I didn't hear you, sir.
Hello?
Hello, sir. I can hear you now, sir. I didn't hear the question.
So have you recorded the distance in the rural areas? What is the distance between the center and the beneficiaries?
On an average, 2 to 3 kilometers for rural area and less than 1 kilometer in urban area.
So was it significant that the beneficiaries having constraint because of the distance in your study? Was it significant?
Yes, sir.
Yes, how much it was? So show me the slide where you have recorded the distance. Show the slide.
I've not put it on slide, sir.
You're not able to show.
The distance I've not.
So in the rural areas,
Distance
it
I've
was
not.
more. So two people had a constraint in distance in the rural area.
Sorry, sir. I've not displayed the distance, sir.
But the number of people.
Sorry, sir.
Hello. So only two people were having a constraint in the distance.
Yes, sir. There were hardly any constraints recorded, sir. Very less than what was anticipated.
So
Before
it was
we
not
started the study, we had anticipated more.
So it was not significant.
But only 8 beneficiaries in all reported of any constraints in
Age.
8 out of 81, sir.
They had distance constraint. So out of 81, two had in the rural area, two had constraint in the distance.
since the number is very low.
I cannot hear you properly. Hello?
Yes.
Okay, so are there any other national health programs which are concerned with the antenatal checkups provided for the pregnant women? Any MCH programs other than the PMSA? Yes. Can you mention any other schemes or any other programs concerned with the maternal and child health? Hello? Hello?
So I'm sorry, but I think time is up. We have to carry on with our next session.
Okay, okay, thank you.
Okay, I would like to thank all the participants for putting in so much time and effort and making this session so knowledgeable. I would also take this chance to thank our esteemed judges, Dr. Narayan and Dr. Farah, on behalf of the whole committee for providing such insightful feedbacks and making this session so informative for us. Thank you so much for your patience and time, sir and ma'am.
Okay, okay, thank you.
Thank you.
Madam?
Thank you.
Hello?
Yes, sir.
Hello?
Okay, sir.
Now we have to send email the mark evaluation list.
Yes, sir.
Hello?
Yes,
Now
sir.
I'll send the email now.
Yes, sir.
Okay, okay. Thank you, madam.
Thank you, sir. Thank you so much.
Thank you.
Thank you, ma'am. I request all the participants to leave so that of this session to leave so we can start the next session. I'm so sorry for the delay. The other session took a little longer because we had some technical glitches. We'll be starting just in a minute. Thank you so much for your patience. Before we begin, we'd like to do a roll call. Dr. Swapna. Dr. Swapna, can you unmute yourself? We just want to have a sound check. Dr. Ramya.
Yeah, I'm here.
Thank you, ma'am. Dr. Smita.
Yeah, I'm here.
Thank you. Dr. Shweta.
Good afternoon, I'm here.
Thank you, ma'am. Dr. Amogashri.
I'm there.
Thank you, ma'am. Dr. Swapna, are you here with us? Ma'am, you're not audible. Dr. Swapna? Ma'am, we are unable to hear you. You're unmuted, but we are unable to hear you. No, ma'am, you're not audible. Your voice is... You'll have to raise the voice of your mic on your phone. You're extremely soft, ma'am. No, ma'am, it's very soft. Ma'am, you can try it without using your headphone in case that works. Because... Okay, until ma'am fixes her mic, let's start the session. Good afternoon, everybody. Welcome to the 32nd
Can you hear
state
me?
level. Yes,
Can you hear
ma'am.
me now?
Yes, ma'am. Yes, ma'am. You're audible now.
I think I will use without the microphone. I think it is better with the computer setting. Am I clear?
Yes, ma'am. Yes, ma'am.
So can I start presenting?
Ma'am, just 2 minutes. I'll introduce the conference and the rules, and then you can continue.
Okay, thank you.
Thank you, ma'am. Good afternoon, everybody. A very warm welcome to the 32nd State Level Annual Conference of Karnataka Association of Community Health, hosted by Ramaya Medical College. The theme of this year being Redefining Public Health, COVID-19 and Beyond. Today, myself, Surbi, we are the moderators. We are 7th-term students from Ramaya Medical College. I'd also like to take this opportunity to introduce our judges. Our judges for today are Dr. Suvarna, Professor and Head of Community Medicine Department from MVJ Medical College, Bangalore, and Dr. Poonam Nayak, Professor and Head of the Department of Community Medicine from Yanapoya Medical College, Manipal. Thank you so much, ma'am. It's such an honor to have both of you here, and we're really looking forward to a very informative and insightful session with your valuable feedback. Thank you so much for taking your time off for our session and judging our event. Now, let's just go over the rules. So every participant will have 6 plus 2 minutes. So the 2 minutes will be the question answer session by the judges. And in the 6 minutes, we will be giving you an intimation at 5 minutes to stop, to tell you that 1 minute is left for your presentation to get over. So let's begin now. Dr. Swapna, I'll be giving you the control so you can start presenting.
Yeah. Is the slide visible?
Yes, ma'am. It's visible, ma'am. You can start.
So can I start now?
Yes, ma'am.
Fine. Good afternoon, respective judges and co-participants. I am Dr. Swapna from the Department of Community Medicine, Associate Professor from Rajarajeshwari Medical College and Hospitals. Today I am presenting my study titled Breast Cancer Awareness and Breast Self-Examination Practice among Women in Rural Field Practice Area of a Medical College, Karnataka. Well, to introduce my topic, breast cancer is one of the most common cancer, impacting 2.1 million women worldwide, and also the leading cause of cancer death in women, accounting for 15% of death worldwide. Breast cancer is also one of the commonest cancers in Indian women overall. The incidence rate of breast cancer is very high in the developed countries, but the mortality rates are very high in the developing countries. Why? That is because of screening. Screening for breast cancers has a favorable effect on mortality from breast cancer. So the screening techniques available for breast cancer includes breast self-examination, clinical breast examination, and mammography. It is seen that women who correctly practice breast self-examination on a monthly basis are likely to detect the lump at the earliest stage, and which results in early treatment and better survival. With the importance of breast self-examination in the early detection of breast cancer, the fact it's cost-effective and easy to perform, this study was conducted with the objective to assess the level of awareness and practice of regular breast self-examination among the rural women in the age group of 18 to 60 years in the field practice of Rajarajeshwari Medical College and Hospitals. Well, continuing with materials and method, this was a community-based cross-sectional study which was conducted at Chunchunguppe and the surrounding 8 villages, which comes under rural field practice area, which was conducted from the month of May to June 2019. The sample size was 516. They were representative from all the 8 villages. Inclusion criteria was women between 18 years to 60 years of age and who were available at home during the time of interview. Pre-tested semi-structured questionnaire was used to collect the data. Statistical analysis, EPI-info software was used to analyze the data. The mean standard deviation was used to calculate the quantitative variables, whereas the frequencies in percentage for the qualitative variable. The association between the variables was tested using chi-square. Well, coming to the results, this table shows the socio-demographic details of the study participants. For the ease of presentation, the data was divided into binary variable. The mean age of the study participants in this study was around 36 years with a standard deviation of 8 years. Most of the study participants were married and most of them were housewives. And the education status of 85% of the women was high school and below, and 83% of them belonged to below poverty line. This table depicts the knowledge of breast cancer. When the question was asked, have you ever heard of breast cancer? It was shocking to know that 55% of the study participants didn't know what breast cancer was. And among those who knew, that is 44%, said that it was preventable. And coming to the source of information of breast cancer knowledge, they got most of them knowledge from the media, books and magazine, which accounted for 56% of the study subject, whereas hospital was 24%. And with the history of family members diagnosed with breast cancer, it was seen that 13% of the study subject had one or the other family members diagnosed with breast cancer. Well, this table depicts the knowledge and practice of breast self-examination. For the questions, have you heard of breast self-examination? Only 72 participants of the total 516 participants, that is 14%, had ever heard of breast self-examination. And among them, only 43, that is 8.3, had been ever taught to do a breast self-examination. And regarding the practice of breast self-examination, 37 of the 516 practiced, which accounted for 6%. But out of the 72 who have heard of breast self-examination, 51 practiced breast self-examination. So this is the table depicting the association between the various socio-demographic details and awareness of breast cancer. There was an association between education and occupation and awareness of breast cancer, which was statistically significant. This table shows the association between the various socio-demographic profile like education, occupation, and income, and practice of breast self-examination. It showed that, again, education and income was associated with practice of breast self-examination, which was statistically significant. Well, to conclude my study, I would like to conclude telling that the awareness regarding the breast cancer, as well as knowledge and practice on breast self-examination is poor among the study subjects. Based on this conclusion, I would like to recommend and promote breast self-examination being one of the simple, cost-effective and non-invasive screening method could prevent morbidity and mortality from breast cancer, especially in Indian scenario. And effort must be taken by the health sector to disseminate awareness and health education on risk factors, prevention, and to perform breast self-examination for females in the reproductive age group during their visit to health centers. So these are my references, and thank you.
Thank you, ma'am. Over to the judges, Dr. Suvarna, and Dr. for the question and answer section.
Hello.
Hello.
Dr. Poonam here.
Yeah. Good afternoon, ma'am.
Yeah. So, Dr. Swapna, overall good presentation.
Thank you, ma'am.
Yeah. Can you please elaborate on the method of sample size estimation and how
Ma'am, actually, the knowledge of breast cancer awareness was taken from the previous literature, which was around 46%, considering that the sample size was estimated to be around 320. And we had 25 villages in the rural field practice area. Using a simple random sampling, we picked up 8 villages, and complete enumeration of all the females belonging to 18 to 60 years of age were included by doing a house-to-house survey.
Okay. Okay, next is there was a question on how many of them are practicing self breast examination.
Yes, ma'am.
Yeah, so but there are certain steps to ensure that self breast examination is done in the appropriate way. Did your study try to capture that information?
Ma'am, we asked them whether they knew, and then later followed by that, they knew the exact way how to do the breast self-examination.
So was that variable being included in your study?
Yes, ma'am.
practicing breast self-examination?
Yes, ma'am.
So what was the proportion of women practicing correct breast self-examination?
It was 8%, ma'am.
Okay, fine, thank you. That's all from my side.
Yeah.
Dr. Suvarna. Dr. Suvarna, you can ask questions.
Do I have question?
Yes, ma'am. Suvarna has to ask you questions. Just a minute.
Yeah.
Dr. Suvarna, can you hear us?
Hello, Dr. Swarna. I'm not sure. I don't think we are able to hear you. If you have questions, please enter it in the chat.
Sir, you're not audible.
Hello?
Hello?
Dr. Suvarna?
Am I audible?
Yes,
Am I
yes.
audible?
Yes,
Yes,
ma'am,
ma'am.
here.
You are, no, I was.
Yeah. I'm not able to share the screen, see the screen. Okay. Regarding this breast cancer this, how was the response of the participants about the practice, like breast self-examination? You
Ma'am,
asked them.
as I told you that the awareness itself was very less regarding the breast cancer itself. They didn't know what was breast cancer. And then the number of participants who knew about breast self-examination also was very less. So the 8% were the only one who practiced on regular basis. So it is very, very poor.
What was the age group? What was the age group?
18 years to 60 years, ma'am.
No. Who actually knew about those 8 people who knew about breast self-examination? What was the age group?
They were in the reproductive age group of 20 to 35.
Because in a rural population, knowing about breast self-examination and practicing it, I think
Yes,
it
ma'am.
is it's very even to listen about those how to do breast self-examination must be a difficult thing when you.
True, ma'am.
Did you do any health education sessions?
Yes, ma'am. Following this, we had a education in the rural health training center itself
Okay.
for them, and the females were called upon, and we did a health education for them by showing them how to do by video demonstration.
And did you do a post test?
No, ma'am, I haven't done a post test.
Okay. Because if after some days, I think you can continue with your study and you can do a post test
Sure,
about
ma'am.
this. Okay, it's a good study.
Yeah, thank you, ma'am.
Thank you, ma'am. Our next presenter is Dr. Ramya KS. I'll be passing over the controls so that you can present.
Hello, am I audible?
Yes, ma'am, I'll be giving you the control.
Okay.
Yes, ma'am, I've passed over the control.
Can you see the slide?
Yes, ma'am, we are able to see the slide. I'll be starting the timer now.
Okay, thank you.
Thank you.
A very good afternoon to all. I'm Dr. Ramya, Assistant Professor, Department of Community Medicine, Sri Siddhartha Institute of Medical Sciences and Research Center. My topic for today's presentation is common mental disorders among married women in an urban locality in Bangalore. Mental health is an integral and essential component of health. As WHO rightly says, there is no health without mental health. In 1992, doctors Goldberg and Huxley, recognizing the public health implications of psychiatric illnesses, introduced the term common mental disorders in the literature. Common mental disorders include depression, anxiety, and somatization. They are the non-psychotic affective disorders, and they are currently classified as a separate diagnostic category in revised ICD-10. Patients with common mental disorders are more often seen in the primary care and general medical settings, and they come with the complaints of subjective weakness, headache, and vague somatic sensations. Because of various biopsychosocial factors like puberty, pregnancy, menopause, and gender discrimination, social exclusion, women are at increased vulnerability for common mental disorders. Because of the varied presentation and fluctuating presentation, the common mental disorders often go undiagnosed in the primary care settings. The non-specific somatic symptoms are often prescribed with painkillers, vitamins, iron, and calcium supplements, and these patients are subjected to unnecessary investigations. As the underlying cause is not treated, the symptoms recur, leading to repeated hospital visits. To have an estimate on the prevalence of common mental disorders among married women of reproductive age group, this study was conducted in the urban area, Chennasandra, an urban locality in Bangalore. To describe and the second objective was to describe the socio-demographic profile of the married women in reproductive age group. This is a community-based cross-sectional study conducted in Chennasandra, Bangalore in the year 2016 and 17. Among the married women, 430 married women in the reproductive age group were selected. This was how the sample size was calculated. Considering the previous prevalence of 32.9%, the values were substituted in the formula, and considering the allowable error of 15%, a sample size of 348 was got, and considering the non-response rate of 20%, 430 sample size was determined. The study participants were selected using simple random sampling, these method. Total number of women in reproductive age group residing in Chennasandra were colony who were married were enlisted. That came to around 1043. All the eligible women were enlisted, excluding 22 women who were residing there for less than 6 months, who came under the exclusion criteria. 430 random numbers were generated using Microsoft Excel, and the final list of 430 randomly selected married women were made. In this, 9 women refused to give consent, so the next house was selected for the study. All the study participants were administered the pre-tested semi-structured questionnaire. The study tool here used was self-reporting questionnaire 20. This was developed by WHO as a screening tool for common mental disorders in primary care settings. This is a tool with the proven reliability and validity and can be used with minimal training. It has 20 close-ended questions with a reference period of preceding 30 days. A standard cutoff score of 7 was used to diagnose the common mental disorders. Ethical clearance was approved, and written informed consent was obtained from each participant. And the data was analyzed in SPSS version 21 using descriptive statistics and suitable tests of significance. Coming to the results, in this study, the mean score of the SRQ was 4.1 with the standard deviation of 3.7. The least score was 0 and the highest score was 13. Those people who had the score above 7 were referred to the psychiatric department for further management. Taking the standard cutoff of score of 7, it was found that the prevalence of common mental disorders was 33.2%. That is, 143 women among 430 women had common mental disorders. This table 1 shows the distribution of study participants according to the socio-demographic characteristics. As you can see, 31% of the women belong to 20 to 24 year age group, and 31%, 29% belong to 25 to 29. Majority of them were Hindus, and more than half belong to lower middle class to Kupaswamy socioeconomic classification. Coming to the educational status, around 76% of the women were literates. Among them, 26% had studied up to high school, and 21% up to diploma. This graph, the women were homemakers, and around 15.8% were employed as semi-skilled workers, and 12% were employed as skilled workers. This graph shows that around 70% belong to the nuclear family. The distribution of study participant according to husband's socio-demographic characteristics. Around 40% of the spousal age was 21 to 30 years, and coming to education, around 37% of the spouses had studied up to diploma, and 25% were graduates.
So, but your time is up.
Okay. Through the slides, this is the pie graph showing the husband's personal habits, and these are the various other demographic marital characteristics: sharing problem with husbands and decision autonomy of decision, traumatic life events. This was conducted to find out the association between various characteristics studied and the self-reporting questionnaire score. It was found that the marital status, the age, the education, the occupation of the female, and the type of family, and also the husband's age, husband's education, age difference between the husband and wife, the personal habits of the husband, sharing problems with the husband, and history of adverse pregnancy outcomes had the statistically significant association. At the end of univariate analysis, multivariate analysis was conducted to know the association. Here the variables which were statistically significant were the age of the women, their education status, the type of family, husband's.
Ma'am, it's been past 6 minutes. We request you to stop.
Yeah, thank you.
Thank you, ma'am. Thank you, ma'am. Over to the judges.
Yeah. Good evening, Dr. Ramya.
Good evening, ma'am.
So it's a socially relevant study.
Thank you, ma'am.
Because you have to run through the slides, can you please highlight what is your conclusion from your study findings and what would you recommend?
Ma'am, it was found that there was a statistically significant association between the age, education of the woman, the family type, the husband's education, and also the age difference between the husband and wife, and the communication, basically the communication between the husband and wife, and some traumatic life events. And so all these things had a role to play in the mental disorders of the woman. So if there is a scale where the primary care physician can recognize, because these are the people who will go to the first physician of first contact, if the person can diagnose these at the grassroots level itself and give the suitable counseling and the treatment required for them, then it will be
if we look from preventive aspect, most of these look as non-modifiable risk factors, isn't it?
Exactly, ma'am.
As a preventive physician, what would you recommend so as to reduce the burden of common mental health disorders amongst the women in the community?
Ma'am, to have a better education system, then communication, improving communication with not only husband, with the family members, so that the lady can discuss her whatever issues and then solve them. That would be the preventive one. Basically, to educate the women so that they can face the issues, whatever they're facing, with greater confidence.
So I would like to put it this way, maybe inclusion of life skills and adolescent health education in the school curricula would be of more relevance in this particular aspect. Thank you.
Yes, ma'am. Thank you, ma'am.
Hello. Good afternoon, Dr. Ramya.
Good afternoon, ma'am.
Okay, your study was very good, but you took time in presenting the basic details about the demography. Okay, we wanted to look with the statistical significance at the later part.
Yes,
Okay,
ma'am.
so
Yes,
I
ma'am.
want to know that did you consider the age at marriage of the woman in your
Yes,
study?
ma'am. Yes, ma'am. As you saw, the tables were a lot. There were a lot of tables,
Lot of
ma'am. So,
yeah.
yes,
So
ma'am.
age of
So,
marriage was it significant?
age of
Like
marriage
at
on.
what age they got married, the
Yes,
girls?
ma'am. There were a few girls who had married below the age of 18 also, ma'am.
No,
But the
I don't want
numbers.
to ask that.
Yes,
Like
ma'am. Yes, ma'am. Tell me.
among your score above 7, okay,
Yes, ma'am.
those
Under
women who have
univariate. Yes, ma'am.
analyst, okay, the women having score above 7,
Yes,
who
ma'am.
were how many were have had their marriage at an early age?
I'll just let you know.
No, did you
It
consider
was,
that?
yes, ma'am, there is a table
Yeah.
regarding that, but due to
Okay.
the increased number of this one, I could not put it.
So
Age
can
at
that be?
marriage, yes, ma'am.
Okay.
That actually came as a statistically significant factor in univariate analysis, ma'am. While considering it for multivariate, it didn't show statistically
Okay,
significant
so what was
association.
the age group did you consider that if a woman gets married a girl gets married less than 20, is she more prone for mental disorders or above 20, anything like that?
Yes, ma'am. According to my study, the age at marriage above 22 was, I mean, below 22 was having statistically a significant association.
Significant. So because as you know that government is considering to increase the age of marriage, isn't it?
Yes, ma'am. Yes,
Are
ma'am.
you aware of that?
Yes, ma'am.
So one of your recommendation might be that the age of marriage for a girl can be increased. Okay.
Yes, ma'am.
So any other recommendation will you give?
My main recommendation would be the early diagnosis, ma'am, at the primary level. This tool should be included at the primary care level, ma'am, so that more and more, because that would lead to solving the problem at the grassroots level, so that the repeated visits will be avoided.
Okay. More psychosomatic complaints were more among this women or some other?
Yes, ma'am. More of backaches and weakness,
Okay.
unexplained
Any
reason for weakness.
history of domestic violence did you take?
History of abuse I've taken, ma'am, but on multivariate it was not, only very few women, because it's a sensitive issue. Very few women could answer that they were undergoing physical abuse.
Okay. Thank you, Dr. Ramya. Thank you.
Thank you, ma'am. Thank you, ma'am.
Thank you, ma'am. Our next participant is Dr. Smita. I'll be passing over control to Dr. Smita so that she can present. Dr. Smita, you should be able to present now.
Is it all visible, ma'am?
Yes, ma'am, we can see your slides. Can I start the timer, ma'am?
Yeah. Good afternoon, judges and my co-colleagues. Today I'll be presenting a study on the prevalence of alcohol consumption and tobacco use among young adult male students at a degree college in Koppal City. As we all know, the development of healthy behaviors, attitudes, lifestyles during young age can contribute significantly to a person's in current and future well-being. Alcohol consumption and tobacco use are important preventable risk factors for many non-communicable diseases like hypertension, stroke, coronary artery disease, cancers, and these are usually established at a very young age. As there are fewer studies among the adolescents in this region and timely identification of the various reasons for alcohol and tobacco consumption, we undertook this study with the objective to estimate the prevalence of alcohol consumption and tobacco use among male students in the study setting and to identify the various reasons associated with alcohol consumption and tobacco use among them. The methodology, it was a cross-sectional study conducted at a government degree college in Koppal City for a 3-month duration from July to September 2019. And the minimum sample size calculated was 342 with an absolute precision of 5% and a significance level of 0.05, considering 32% prevalence of alcohol consumption among adult males in Karnataka as per recent estimates. The sampling, it was a multi-stage sampling in which the sample size calculated was 342, but we included 360, 120 from each cadre, that is science, commerce, and 120 from arts. And among this 120, 40 from first year, 40 from second year, and 40 from third year by simple random sampling. Thus, we have included 360 participants. The data collected was using a pre-tested and a semi-structured questionnaire after taking an informed consent. And statistical analysis was done using Microsoft Office Excel 2013. And ethical clearance was obtained from Institutional Ethics Committee. Coming to the results and the discussion, it's the socio-demographic profile of the study participants. Around 32% of the study participants were 18 years old. The mean age of them was 19 years. And around 88.6% were Hindus, and approximately around 93% were residing in their homes, and the rest 7 were from hostels, and around 79% were from rural background. This is the table showing the various demographic profile of the study participants. Coming to the prevalence of smoking among the study participants was 5%, similar to the findings of study done by Neti GK et al. In Assam, and the prevalence of smokeless tobacco consumption was 3%, in line with the findings of another study done in Udupi district of Karnataka. Prevalence of alcohol consumption in my study was 4%, and presence of both alcohol and tobacco consumption was 2%. The most common reasons for initiation of consumption of alcohol and tobacco, as mentioned by the study, subjects were love failure, stress, and peer pressure by the friends. The main limitation of my study was maybe it might be due to underreporting owing to non-disclosure of the consumption status by the study participants. To conclude, I would say that the prevalence of alcohol consumption and tobacco use in my study were within limits in the study setting, and further research is recommended to confirm the findings with larger sample size and also to identify the determining factors for effective planning of intervention. These are my references. Thank you.
Thank you, ma'am. Over to the judges.
Yeah, good evening, Dr. Smita.
Yes, ma'am.
Yeah. So regarding your study, if we look at, there are a couple of studies, even the Global Youth Tobacco Survey speaks about consumption of tobacco both in smoking and smokeless forms amongst the youth. Okay, so and there are many studies done across the country in different pockets. So I would be more interested to know how would you utilize your study findings, or what will be the implications of these study findings?
Ma'am, we can, to get a better knowledge on the various risk factors, we can do qualitative studies, ma'am. As we can say that the study participant didn't reveal their findings. What, depending upon what they thought, it will not be a confidential. So many of them, we think they didn't respond properly.
Okay. So that would be a further research.
Yeah.
Yeah. Anything else that you would like to recommend as an intervention?
Ma'am, behavior change, this information, education, and communication, ma'am. To tell them about the various risk factors, how they can inculcate the healthy habits right from their engage, IEC and the BCC methods.
Yeah, so it would be more meaningful to address this through the primordial intervention strategies. Okay, yes. And second is it would be more meaningful to explore in detail the reasons or the facilitating factors for consumption of tobacco and alcohol both through using qualitative study tools like in-depth or FGD. That would help you to plan your intervention. Yeah, that's all. Thank you.
Good afternoon. As Dr. Poonam Naik said, there are
Ma'am,
many
it's not
studies.
audible, ma'am.
Hello, it's not audible
It's very
now.
slow, ma'am. Very soft. Yeah, ma'am.
Hear me?
Yeah, ma'am.
Yes, ma'am, we can hear you.
Yeah. So there are many studies that are conducted regarding this alcohol consumption and tobacco.
Yes,
So,
ma'am.
the objective of your study was to find the prevalence, and the
Yes.
limitation that you have told in your study is the underreporting. That we can clearly see that only 4%, I think, have been found to be consumption of tobacco or alcohol, right?
Yes, ma'am. Yes, ma'am.
Yeah. So your study would have been more relevant if you would have stressed upon the factors that are like determinants for alcohol consumption and tobacco consumption in young adults. Which age group have you taken?
Ma'am, from 19 to 24 years, ma'am.
19 to 24, and most of your participants were staying at home.
Yes,
Okay.
ma'am.
So the actual you would have not got the actual data regarding their consumption, because
Yes,
most of
ma'am.
they are staying at home. The consumption might or might not be more, isn't it?
Yes, ma'am. Yes, ma'am.
So if it would have been better if your population was house, home and hostelites, then you
Yes,
would have
ma'am.
got the real status of actual consumption and the determinants.
Yes, ma'am.
And the duration. Have you considered the duration of consumption of alcohol and tobacco?
Yes, ma'am.
How
But
long
they didn't tell the proper thing, ma'am. Only one or two have only responded, ma'am, among all the 360, ma'am.
Okay.
They have skipped those questions, ma'am. So that is the main limitation, ma'am, because we had so many determinants in our questionnaire, but we didn't get the proper response,
Okay,
ma'am.
I'm not able to hear you. Okay. What do you think? What recommendation will you do?
Ma'am, I
Hello?
would prefer to go. Hello? I would prefer for a
Hello?
quantitative research study, ma'am.
Hello, can you hear me?
Yes, ma'am, it's
Mika?
audible. Yes, ma'am, it's audible. Hello? Hello?
Okay, no. What recommendation did you give to that school or college, whatever uh, in which you,
Hello? Ma'am, it's not audible. Hello?
Dr. Suvarna?
Ma'am, it's not audible.
Dr. Suvarna?
Is there a problem?
Hello? Hello?
Dr. Smita, can you please wait for 2 minutes? We are trying to contact Dr. Suvarna.
Okay, ma'am.
Dr. Suvarna, can you please try unmuting your mic?
hello, can you hear me?
Yes, ma'am, we are able to hear
Hello.
you now. Yes, ma'am, we are able to hear you. Your voice is
Okay,
audible.
thank you, Dr. Rami. I'm sorry. Yeah, sorry. Sorry for the, I don't know, there's some internet issue over here. So it would Dr. Smita, it would have been good if you would have taken more determinants and if you make more recommendations regarding this study. So thank you, Dr.
Thank you, ma'am.
Thank you, ma'am. Our next participant is Dr. Shweta Shri M. I'll be passing over control to Dr. Shweta.
Thank you.
Ma'am, I've passed over the control. You should be able to present.
I hope it's visible.
Just a second, ma'am. It's not yet visible. Ma'am, your PPT is visible now. Can I start the timer?
1 second.
Yes, ma'am.
Yeah, you can start.
Okay.
Good afternoon, my respected seniors and dear colleagues. Myself, Dr. Shweta Shri, Assistant Professor from JSS Medical College, Mysore, will be presenting our study on prevalence of iodine deficiency disorder among school children of Mysore, a cross-sectional study. Coming to introduction, iodine deficiency disorder is said to be the most common cause of preventable brain damage worldwide. Children who are born in iodine deficient areas are found to have 13.5 intelligence quotient, points lesser than that of children born in iodine sufficient areas. It has also been estimated that a 1 point increase in the nation average IQ is related to annual increase of 0.11% of GDP. In recent years, surveys outside the conventional goiter belt have identified many endemic foci of iodine deficiency, even in other parts of India. Government of India has made iodized salt containing 15 ppm of iodine among the beneficiaries. Urine iodine concentration is a good marker for estimating a very recent dietary iodine intake. Keeping this in mind, this study was conducted to evaluate iodine status and prevalence of goiter in school children aged between 6 to 12 years in Mysore, Karnataka state. Our objective was to study the prevalence of goiter in children aged 6 to 12 years, to analyze the salt iodine level at the consumer level, to identify the median urinary iodine excretion among the children. Coming to material and methods, it is a descriptive cross-sectional study which was done in Mysore district for for a duration of 7 months between April 2019 to November 2019. Mysore district has 7 taluks, 30 lakh population, wherein 41.5% people are residing in urban. There are 1199, that is 1199 villages and 80 wards. So that detail was taken from the recent census, that is 2011, from where we calculated the sample size based on the 2014 study which was done and which had prevalence of 8.77% with 5% level of significance and 80% of power. We got around the sample size as 2,700 700. And using a population proportionate to size and systematic random sampling technique, 30 villages and wards were selected, and clinical examination of these 2,700 students were done, wherein 90 children were selected from each village. So 90 children into 30 villages, we got we could cover 700 sample size, wherein in each school 45 boys and 45 girls were enrolled based on age proportionate distribution, which was chosen, and also by systematic random sampling. Salt samples were collected from these students that by every fifth child was chosen among this 90 children. So we got salt from 540 household, the corresponding child. And 270 urine samples were collected from these 270 children. That is, every alternative child was selected for collecting urine sample. Students from each age group, that is between 6 to 12, were selected based on the following calculation. That is, in each school, 45 girls and 45 boys are selected, wherein they were grouped into 6 to 12 years. That is, 7 group was made. From each age group, 6 or 7 boys or 6 or 7 girls were selected based on that is 45 by 7. We got approximately 6.4. So based on the preferability, we got 6 to 7 girls or boys from each school. So children who were between 6 to 12 years, who were residing more than 6 months and were going to from that selected area. And household we were residing from more than 6 months were selected. This was our inclusion criteria. And children who were below 6 years and above 12 years were excluded. And biochemical analysis was done for salt iodine level by iodometric titration method and urine iodine excretion by Sandel-Kolthoff method. Data analysis was done. Data was collected in MS Excel and was followed by analysis by SPSS version 22, licensed to our institution. The data were represented using arithmetic mean, standard deviation, percentages, bars, and pie diagrams. Coming to the ethical consideration, we were funded from Deputy Director of Nutrition, IDD Cell, Director of Health and Family Welfare, Government of India, under NHM mission. We took informed consent from the parents and class teachers and also assent from the children, along with an official letter from DDPI and ethical approval from our institution. Coming to the result, through our result, we got to know the goiter prevalence in Mysore to be 2%, wherein it's more among girls, that is 2.5%, and almost nearing, that is 1.9% among the boys. And salt iodinization level out of 245, we found that around 51.6% had more than 15 ppm of iodization. Yeah. And coming to the frequency distribution, median urine iodine excretion was found to be 210 microgram per liter. And we found through our study that almost 65% of the children had urinary iodine excretion between 200 to 299, which was more than the required, and 35% had adequate, that is between 100 to 199 microgram per liter. Conclusion, through this we want to conclude that a transition is seen, because as of when we calculated the sample size, we got to see that the prevalence was 8.77% in 2014, and now it has come to 2%. So the goiter prevalence from endemic to it's becoming non-endemic in Mysore district. Coming to the recommendation, advice to continue compulsory information, education, and communication activities to the school children, teachers, and also for the general public regarding the consumption of iodine salt and also health problem of this iodine deficiency. Monthly iodine level to be checked from salt at production level, and also strengthening the system of monitoring the quality of iodized salt provided to the beneficiaries should be continued to progress towards the elimination of IDD, and also other reasons for goiter should be evaluated through hormonal assessment and also the sampling test of iodine salts used at midday meals centers.
Time
These
is
are my
up.
references. Thank you.
To you, judges.
Yeah, thank you, Dr. Shwetashri.
Thank you, ma'am.
Yeah, so that was a good study.
Thank you, ma'am.
Because you're running out of time, so you could have planned the time management so that you could have focused more on the results rather than the sample size estimation. Okay, so that is one point which you can keep in mind for your future presentations as well.
Sure.
One more thing I would like to know is, out of those who had goiter,
yes, ma'am,
did you try to analyze or explore the reasons for the iodine deficiency disorders among those who you have found this disorder?
No, ma'am, we could not do, because we could examine and found out, and we gave the same information to the district authority for the further analysis.
Okay, fine. Thank you. That's all from my side.
Thank you, ma'am. Thank you.
Okay, good afternoon, Dr. Shwetashri.
Good afternoon, ma'am.
This study is good, and I think some 2 or 3 years back there was a similar study done by Mysore Medical College regarding iodine deficiency disorder.
Yeah, ma'am. 2014 they have done, ma'am. Yeah, ma'am.
2014, yeah. But in your references, did you refer that study before conducting your study?
Yes, ma'am. We had referred.
Okay. And in your recommendations, your recommendations are good, but in your recommendations, you have told, means in your conclusion, you have told that Mysore district is going from endemic to non-endemic. Is
Yes,
this
ma'am.
based on that study? What was the reference?
Yes, ma'am. That reference on the same, which had
The
like
same
when.
one, the
Yes,
prevalence
ma'am. Yeah, yeah,
from that
prevalence.
study.
Yeah, yeah, ma'am.
You compared with that study.
Yes, ma'am.
Okay. The same in your the sampling, whatever
Yes, ma'am.
was the same, means
No,
the
ma'am.
area
For
which
them,
was
because they had taken two districts, ma'am. They had taken Mysore and Coorg that time, and
they
also they had
compared
taken.
Mysore and Coorg,
No, ma'am. They
but
had
my
taken together. Yeah, ma'am. And they had
no,
taken even. Yes, ma'am.
I
Sorry.
just wanted to know which part of Mysore was the part of Mysore same between your study and their study.
No, ma'am. They had taken both Mysore and Coorg together, and they had calculated sample size by taking Indian prevalence that time.
Okay, yeah, they compared between Mysore and Coorg, isn't it?
Yes, ma'am.
No, I
Yes, ma'am.
want
Yes,
to
ma'am.
know the part of Mysore, means which part of Mysore you took for sampling.
The whole
The
Mysore we
whole
took,
area
ma'am.
you took.
Yeah, whole
Okay.
area, ma'am. Both
Okay.
rural and urban, both we took, ma'am.
Okay, so what was their prevalence and what was your prevalence?
Theirs was
For any-
8.77%, ma'am. Ours is 2%. And in this
Okay.
2%, among 4 villages and one our ward, we found these clinically cases we have found,
Okay,
and we
was there any
reported the same.
difference, gender difference, gender difference?
It's almost same, ma'am. It was higher among the girls only, even in their study also.
Girls, yeah. In their study, it was very, very high among
Yeah,
girls.
ma'am.
So has that difference reduced over time?
Yes, ma'am.
Did you
But
try to find out why?
maybe intensified workup from the district authority. We have just thought, ma'am, not yet found.
Okay. Okay, because when I was going through the study, the prevalence in girls were
Yes, ma'am.
very high compared to the prevalence in boys.
Yes, ma'am.
And in your study, I just wanted to know what was the prevalence in girls compared to boys.
Among girls, it was 2.5%, ma'am. Boys, it was
And
1.9%.
okay, so was it significant?
Yes, ma'am. It was a significant, yeah, ma'am. Significant.
Okay. 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 Thank you, Dr. Shweta.
Thank you, ma'am. Thank you all.
Thank you, ma'am. Our next presenter and the last presenter is Dr. Amoga Shri. I'll be passing over the control.
Good evening, everyone.
Ma'am, you should be able to present now.
Yeah, I'm trying to share. Is it visible?
No, ma'am. Not yet.
Now?
Sorry, ma'am, it's not visible.
Okay, just a second. I'll try again. Is it visible now?
Just a second, ma'am. It's loading. Ma'am, your PPT is visible now. Can I start the timer?
Just a second. Okay, start.
Yes, ma'am.
A very good evening to everyone. Myself, Dr. Amoga. I'm working as a senior resident at Department of Community Medicine, JSS Medical College. My topic for today's presentation is self-reported emotional and behavioral difficulties among pre-university college students of Karnataka, a cross-sectional. Adolescence is a stage of transition from childhood to adulthood. That is from the age of 10 to 19 years. During this stage, many psychological changes takes place, and this is a matter of concern, especially among the students. Like when the transition phase is seen when they go from school to the college life, and this makes them more prone to the mental health issues. And even the researchers have shown that majority of adults who suffer mental disorders indicate that their symptoms began either in the childhood or during the adolescence. and the appropriate identification and immediate treatment of mental disorders helps them to overcome the future consequences. With this context, this study was conducted among pre-university students. The objective of this study is to estimate the prevalence of self-reported emotional and behavioral difficulties among pre-university students of Mysuru. It was a community-based cross-sectional study done for a period of 3 months in Mysore, and the sample size was calculated using the prevalence of self-reported mental health problem as 10.5%, and using the formula of OPQ by D square, the sample was estimated to be 144, and considering the non-response rate of 10%, the sample size was calculated to be 158, and we line listed all the colleges in and one college was selected by simple random sampling method, that is lottery method, and from this college students were selected by universal sampling method. Clearance for the study was obtained from ethics committee of the institute. After obtaining assent from the students and consent from the concerned college principal, we started the study, and we included all those who are studying in first and second year pre-university college, and we excluded those who are absent and those who are not willing to participate in this study. Along with semi-structured questionnaire, we included the questionnaire strength and difficulties questionnaire to collect the data, and the data was entered in Microsoft Excel and analyzed using SPSS version 24, which is licensed to our institute. Descriptive statistics like percentage, mean, and standard deviations were applied. Inferential statistic test like chi-square test was applied to find out association, and statistical significance was considered at p-value less than 0.0. And the table 1 is showing distribution of students according to their socio-demographic profile. Here, majority were in the age group of 17 years, that is 55%, 90.8% were male, 54.1% were studying in first PUC, and 74.8% they were satisfied with their current education, that means the course they have taken in PUC, and 99.1% belongs to Hindu religion, 72.9% resides in nuclear family, 84.4% had siblings, 78.4% mothers were literate, 76.6% students' fathers were literate, 72.5% family members up to 5, and 81.7% they were coming from parents' home, and 18.3% were coming from other places, that is either from PGs or from relatives' house or hostel, and 29.8% belong to class 3 of socio-economic status, and 41.7% belongs to class 4 of socio-economic status according to modified BG classification. The graph 1 is showing distribution of students according to prevalence of self-reported emotional and behavioral difficulties. We can see it is seen among 67% of the students. And according to graph 2, we can see that emotional symptoms was seen among 16%, conduct problem was seen among 63 members, and hyperactivity was seen among 2%, and peer problem was seen among 16 students, and prosocial was seen among 6 students. And table 2, distribution of students based on the association with socio-demographic profile with self-reported emotional and behavioral difficulties. Here, statistical significant association was noted between educational qualification and emotional and behavioral difficulties. 72% of 9% who were in studying in first PUC, they had this problem. Even though it was not statistically significant, 80% of those who were coming from the home were having was not coming from the home. They were having emotional and behavioral difficulties. To conclude, in our study, there was a high prevalence of emotional and behavioral difficulties, and of this conduct problem was seen more, followed by peer problem. And my recommendation is that educational institute need to identify the students who are at risk and refer them for counseling and treatment. By this means, we can easily early identification and immediate treatment of mental disorders. Students can overcome the consequences like suicidal behavioral or substance abuse or poor academic performance, etc. And these are my references, and I would like to thank the students, college principal, department of community of JSS Medical College, and CatchCon 2020 for giving an opportunity to present. Thank you.
Thank you, ma'am. Over to the judges.
Good evening, Dr. Ramokshri.
Good evening, ma'am.
Yeah, so first thing, for sample size estimation, you have taken the reference value from developing countries. So I would like to know, are there no studies conducted in the Indian scenario, in the Indian context?
There are studies, ma'am.
Wouldn't it have been more appropriate to take it in the Indian context so that it is as close to the local conditions rather than taking in other countries?
It was mentioned as a developing country, but it was done here. I'm not wrong.
Okay, so that is
It
one
was
point.
from international pilot sample study, ma'am.
Okay, so that is first point. Second
Okay.
is in the gender distribution, your study shows that almost 90% of them are males. Any specific reason for this in a PU college?
Actually, we did a study during our school. We included only those who gave consent, and many of the girl students they did not give consent. So those who gave, we included only them. So only 20 were included for our study, ma'am.
Yeah, and your conclusion you have mentioned about peer problem, but has
Yes,
that reflected anywhere in your results?
yes, ma'am. It was seen among 16 students, and borderline was seen among 57 students, ma'am.
Fine. Yeah, that's all from my side. Thank you.
Thank you, ma'am.
Good evening, Dr. Amoga.
Good evening, ma'am.
Yeah, the same thing I wanted to reflect because there's a lot of imbalance between the gender which you took in the sample size, very less amount of girls compared to boys. What was it a factor to like the outcome changed because of that, like the emotional symptoms, your five, whichever slide you're projecting now? So
Yes, ma'am.
those because the sample size was more of boys, did this outcome affect because of that?
Yes, ma'am. Even
Do you think
girls,
like
if
that was the limitation of the study?
yes, ma'am.
Like emotional symptoms, hyperactivity, peer problems, may or may not be, but maybe it, gender had a contributing factor
Yes,
to it,
ma'am.
like a confounder.
Yes, ma'am. If I had included more number of females,
It's
then
equal,
this
almost
result would
equal
have
number.
shown.
Would it be different study?
Yes, ma'am.
Okay. The second thing is, what recommendations do hello? What recommendations will you give? Like other than counseling, what do you think? What other recommendation will you give?
One is like a good relationship with their teachers, ma'am, so that they can share their things whenever they have a problem. It may be like academic performance or any other things, so they can overcome any mental issue at the earliest stage. And they should have a good rapport with their friends also. Hello. Hello.
Hello?
Am I audible, ma'am?
Yes, ma'am, you're audible. Can we end the session, ma'am?
Yes.
We now come to the end of our session. I would like to thank all the participants for their insightful presentations, and I would also like to thank the judges for their valuable guidelines and comments. Thank you.
Yeah, thank you all, and congratulations to all the participants for presenting in CatchCon 2020, and best wishes. Thank you. And thank you to the organizers as well.
Thank you, ma'am.